complicate matters. So confirm, especially in an older child, in a newborn also, before we start doing any of these physiotherapy exercises, we always ask for a plain X-ray, cervical spine epilateral, check out that there is no abnormality of the vertebra, and then only go in. So also in an older child, sometimes there may be an irritating focus there, and that may cause the irritation, and therefore, like you have in the appendicitis, you have the flexion of the lower limb because the psoas is irritated and therefore goes into a spasm. Similarly, if there is a acute inflammatory mass inside, the sternomastoid might go into spasm to give some relief, and therefore there may be an attitude rather than a deformity. So first check out all those things, get a plain X-ray for the cervical vertebrae. Once you are convinced that there is no other problem, then only go in for physiotherapy. Now, usually physiotherapy will not work when the child is above 7 to 9 months. With that, also you will find, if you see, observe carefully, there is a hemi atrophy on the side of the deformity. So that part of the face does not develop. Secondly, see the angle of the eyes. Normally our angle is, the vision is like this. In this case it is like this, and many times a child may have diplopia because he is not used to looking properly. So that is another thing. Thirdly, with physiotherapy what we do is give a collar. We get a collar made such that we have a dimensions taken from the lower end of the jaw to the clavicle on each side. So once we have this will be less. Now you overcorrect this. So you make a cervical collar which is more on the side of the deformity, less on the side opposite to the deformity, and after giving exercises apply that. So that he is in an overcorrected position. If that works with physiotherapy, nothing like it. If after 7 to 8 months you find that it is not improving, or that the child has started developing signs of hemiatrophy on that side, then that is the indication for going ahead and doing surgery. In surgery, there you can see the taut left-sided sternomastoid, which is the shortened one, and therefore the ideal thing is just to incise both the heads. You know that the sternomastoid has two heads, the clavicular and the sternal head. So you need to identify both of them and cut them. Here you can see that I have gone through one of the sternomastoid heads and it is going to be cut. Once it cuts, it retracts. Once it retracts, you actually manipulate the neck under anesthesia, close the wound, and then we give that same overcorrected position for post-operative. Wait for 10 to 15 days because you have just done a surgery, and then restart physiotherapy. So the role of physiotherapy is there pre-op as well as post-op. Post-op more so vigorously. And within few days, you already start getting some reason of correction. It has to progress gradually. Physiotherapy together with motivation by the parents will help this child. Another thing is left-sided huge mass coming up in a small infant. First question, especially on the left-hand side, is when was BCG given? If BCG has been given quite recently and a mass has come up on that side, whether it's in the axilla, it's in the cervical region, you must think of BCG adenitis. And with, again, BCG adenitis, little bit controversy still exists. Different people say different things. I would first give a simple antibiotic and see what happens. If it resolves, well and good. If it does not, the other option is to start INH. INH to be given for at least 3 weeks and see what is happening. Is it decreasing in size? Again, on examination, if you find that the BCG adenitis, whatever is hard, solid, then it's worthwhile taking a conservative approach. If it is soft, cystic, like a cold abscess, I don't think it's going to improve. It's better to nick, take out the abscess, do the dressing, and then maybe give INH for a total of 6 weeks. So with this, most of the times the BCG adenitis should be taken care of. Going from the neck to the tongue and mouth and that area. Tongue tie is a common problem and most of you must be seeing this. The problem with tongue tie is not inability to eat, swallow or talk, except the hard consonants. Where they have to hit the palate, that is the only thing which is affected with a tongue tie. One. And number two, typically after eating food, you clean your insides of the teeth with the tongue, which cannot be done by the child with the tongue tie. So tongue tie needs to be released, yes, but at a time when the child is about to start speaking, which may be around 1 year or so, and again, like in torticollis, requires physiotherapy, tongue tie will require speech therapy post-operative. So before they come to you, don't say, I will do the tongue tie and that's the end of the matter. No, tongue tie followed by speech therapy. Because the tongue muscles have to be retrained to do what they are supposed to do, which they were not able to do physically because zaban ko lagam thi. So we just do it. Many times the frenulum, which is the shortened part, is very thick and vascular. So we either cut it with a pottery directly so that there is no bleeding. And if that is not adequate, many times we take a continuous stitch with chronic catgut to prevent further post-op bleeding. This again can be done as a daycare case, does not require hospitalization. We do it in the morning, by afternoon if there is no bleeding the child goes home. But post-operatively liquids only for the next 3 to 4 days. The liquids have to be either room temperature or cold, no hot or warm liquids to be given. Every liquid feed is to be followed by plain water so that nothing sticks to that part. No solids because that will injure and cause bleeding or pain. And therefore after 3 days they will introduce soft diet and they will go into regular full diet. And that's when you get a full proper release of the tongue which comes out now. The main thing is inability. See, this is now a very prominent and a shortened vascular one, which we cut. Fortunately, there was no bleeding, so now we have got an adequate thing. Sometimes they come again with a fall when they are just having teeth. They fall while running, and then there is a tongue C&W. I have seen patients who have come to me after being sutured in the casualty without anesthesia. I mean, that's criminal. You cannot suture a child with a C&W on the tongue without giving anesthesia in a proper operating theatre. So don't ever even entertain such things. These patients have to be taken under anesthesia so that the suturing is done. Because what happens is this looks like it's a C&W in the front, but it's through and through almost, and you can go on the back also. So what we need to do is first take the anterior stitches, then turn the tongue over and take the posterior stitches. This looks like we have done the anterior stitch. He also has another C&W right there on the lip. And then you go posteriorly and do the suturing also, because if you don't do a proper suturing on the posterior aspect, again it can go into problem. So again, with C&W of the tongue, ideal would be liquids orally only for the next 3 days. That also cold or room temperature, followed by semi-solids, followed by solids. This is how the child looks. There will be caking because they have not been taking water soon after every feed. So the fruit juice or whatever has been given starts caking on the incision. Ranula is another thing which you will see here. They may or may not come with symptoms of breathlessness, but with a huge thing sitting under the tongue. Now in this case, because this is a very important area, if you try to excise the ranula, you might land up either cutting the duct of the salivary gland, submandibular or the sublingual, and cause a parotid or a salivary fistula, so the child will keep drooling. So therefore the idea in ranula is not to excise it, but to lay it open and just marsupialize it. So in these cases, you have to be careful that you know where the frenulum is, you know where the sublingual ducts are, and see that you open it in the midline, drain it of the glary fluid, trim it little bit, and then take continuous sutures on the edges as hemostatic sutures and it prevents it from closing and reoccurring again. Sometimes you even get lesions on the tongue. There was a huge mass over here on the right side of the tongue where you can see the mass, and we were not sure what this was. So the ideal thing would be to excise it. There is no question of conservatively keeping it. There it is the space sutures on the tongue. The whole thing was excised in two parts. This was the defect which was sutured. There was a second lesion which has been excised later on. It turned out to be an odontoid cyst. Now don't ask me what this is because histopathologically I am pretty weak. But there was a huge mass which needed to come out because the child could not move the tongue, could not talk properly, and was in danger of biting on that thing and causing bleeding. Then there is another thing which is known as a submucous cyst, which is just on the inner aspect of the lip, where again there is no emergency. It can be done as a daycare, no hospitalization. What you need is to just take a good incision. There you can see the cyst which is there, and they usually have a habit of sucking it on between the teeth, and that may be the starting point. Small minor trauma which has been repeated over a period of days or weeks, and then the cyst occurs. It's like a retention cyst. What we need to do is take a good incision. It just comes out, pops out like an enucleation, and then close after you have done the routine. Another thing is when a child has fallen, look at the tongue and look at the frenulum of the lip. Very often that can be torn. There you can see the bleeding is there. We always look for the teeth, we look for the cheek, we look for the lips, look for the frenulum also. That needs to be sutured in the midline, and therefore be careful about this. Now, this was another child who had a penetrating injury. Now, he was playing in the compound of his house, his building, and he fell right on one of those spikes. So the injury was somewhere here, and we were not sure what we were dealing with. The X-ray did not show anything. There was no pneumomediastinum, no pneumothorax, nothing. So when we explored the wound, it was pretty deep to the muscle. But what we realized was there was bleeding from the mouth also. So when we looked into the mouth, we found something like a small hole there. And when I pushed my finger from below, I could see the blood in that in the bottom of the thing. So it had gone, fortunately for the child, it had gone parallel to the trachea, and it had come through the, see, that's how it was. It had gone the other way around, gone from here, came up from there. And if he had missed the upper part, he would have had a fistula there, because it would have kept draining, and that would have been a problem. So we had to do suturing below as well as suturing above in the floor of the mouth. This was how it looked from outside. Again, another important one is what is known as the preauricular sinus. You can see the sinus over here, but by the time this child came to me, that sinus was infected, which is why you need to do it before it gets infected. Otherwise you end up with something like this, which becomes very difficult to excise because the skin there cannot be stretched and moved around this side and that side. And we are in trouble because excising the bad skin is a must. Now along with that you need to get rid of the sinus. And therefore what we need to do is, see, the sinus is a small thing. If it is not infected when they are referred to us, before they get infected, before they get complicated, it's an easier job for us. Whereas now, the thing is first to put in a probe, go right up to where the sinus is finishing, and then excise the whole thing in one mass and try to get a proper closure, which sometimes may be not a very ideal incision, which may look pretty bad post-operatively because you have gone through infected, dirty skin, and then you have sutured. And this is the whole sinus with that hole there, the whole thing has been excised in one part. Thank you. If there are any questions, please. Sorry? No, if it is, see, it may not be because of the forceps delivery, but even if it is due to the forceps delivery, it's a fresh wound. Start with physiotherapy. With physiotherapy, properly done by the physiotherapist and the parents of the child, 90% of the times there will not be a problem of having to undergo any surgical intervention.